has osmolar power. So it's pulling the water from the cells into the blood vessels. So now you've got more sugar and more blood and more water in your blood vessels, but you're shriveling up your little cells. So then the kidneys are trying to work through this and, do their due diligence, but the water and the glucose builds up so much in the blood vessels that the kidneys start not being able to reabsorb the glucose. So you start spilling glucose out of your urine. That's why you're,
That's why they pee a lot.
huh?
That's why they pee a lot.
That's why they pee a lot, yes. So, and then they're thirsty a lot because you're basically for both DKA and for both HHS, you're basically starving in the land of plenty. That means you've got lots of glucose on board, but it's not in the cells. So the cells think that they're starving because they literally are starving. So then they start the starvation metabolic process in your body. So specifically for DKA, your body will start breaking down muscle and breaking down adipose tissue to try to give energy to the cells, particularly your brain, because our brain doesn't store glucose in the cells. So when you're doing those, what's the word I'm trying to think of? When those, not equations, but when those mechanisms, that's the word, when those mechanisms are occurring between the breakdown of the protein and the breakdown of the adipose tissue, you have ketone bodies, which are a leftover piece, I guess I should say, of making the glucose. See what I mean? So you break down glycogen, you break down adipose tissue, you break down muscle, and some of those leftover things are acids and ketones. So that's why you get your pH starts really dropping, and you have these ketone bodies left over. So again, the kidneys are not able to filter as well because there's so much sugar. So again, those ketones start being released or being spilled out of the urine. Because I always wondered, how can you spill ketones? But it's because they're not being reabsorbed, you see, because there's a part of the glomerular filtration where things go out, and then another part of it, the lipophilically things are supposed to come back in, but it doesn't come back in, it stays spilled out. So that's why then all this water has to follow, because you have all these ketone bodies and this glucose, the water has to follow it, so then you're dehydrating yourself more and more and more. Is that making sense how that works? Okay. So, it's easier to do DKA first, patho, and then talk about HHNS patho, because the patho for HHNS is similar, but hold on, I want to say it right. But there's no ketone body release, because there is insulin in the bloodstream, so your body doesn't go into the same level of starvation mode as it does when there's no insulin available. It's just not enough insulin to cover the amount of glucose that is in the bloodstream, because that's why, and it's a much more gradual onset, so your body doesn't see that there's this big swing and try to overcorrect in a heightened way as it does with DKA that only takes a few hours. You see the difference there? Anybody not understand that or have questions more about that?
Can you go over the A3 test again?
I'm sorry?
Can you go over the A3 test?
Okay, let's see. I want to say it more clearly, I'm sorry. Okay, so the reason, here's another component of HHNS. The reason that you have such severe dehydration, and the dehydration issue is such a much bigger role in HHNS than it is in DKA, is because you have your glucose levels, Is it okay if I do this for like a hot few minutes?
Mm-hmm.
If anybody doesn't like it, just tell me, don't have to send a message to the director. Okay? Just saying. Okay. 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 No, we've had students who've done that already, that's why I'm saying it, so. Okay. It's really hot in here.
She talked to somebody yesterday.
Yeah, she called Rosa. Rosa is our lady.
That she cut it.
Yeah, but if I call her, then it's gonna get like super cold and you can't regulate this. It's a calamity. Yeah, it is. Okay, so for a person with DKA, you're gonna see insulin levels above 300, okay? But for a person with HHNS, you're gonna see levels above 600, okay? I realized that in their slides it's 400, but the Lewis book says 600. I thought it was 600, and then I saw the slides, and so then I wrote both, but then I was just informed that it is in the Lewis book at 600, so we're gonna go with 600 for HHNS.
That's what it says in API.
Yeah, it's 600.
And DKA is about 250.
250, 300. Yeah. But remember, whenever you're talking about someone without insulin, you have to much more tightly regulate their glucose than someone who has insulin, but they have insulin resistance. Just because, mainly because of the DKA issue, because they're, when you don't have, I'm sorry, I'll get back to HHNS.
No, you're fine.
When you don't have insulin, you swing, when you don't make insulin, you swing a whole lot more than someone who makes insulin, just, it's not, well received by the cells, or they don't make quite enough, the amount of glucose in the body. You see what I mean? It's kind of like, okay, like my husband had to have a thyroidectomy. I can tell you the story later, but I don't want to diverse. I don't want to go swirling off too much. So he gets thyroid medicine, every day. But if he has stressors or whatever, or those kind of things, his thyroid medicine stays like this, where we can do this, to like help regulate our bodies. So it's the same thing with insulin, because you're only getting X amount of insulin. That's why they made all these other kinds of insulins with these peaks and troughs and onsets and blah, 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 all those things. Okay, so back to HHNS. Okay, so with HHNS or HHS, I like HHNS because it tells you that non-ketotic syndrome part, which is the most important part about the difference between the two. So now your blood sugar rises so much, you have basically double the amount of sugar in the bloodstream moving around, that the osmotic pressure or force is double the amount as it is in a DKA patient. So that's why the dehydration is the main issue with HHNS. Is that helping more with
Yeah.
patho? Okay. So, let's see, what was I saying? Okay, so here, now, I could not find this. I think I've read it somewhere, but this just came straight from my memory, but I feel like I read it somewhere, but I can't remember where I read it. But when I was in critical care, when I had HHNS patients, obviously we talked about the number one issue is fluid replacement. So we gave a liter of fluid an hour until their urine output was 30 to 60 mils per hour. Okay? Huh? For HHNS, yes. A liter of fluid per hour. And I know that that's a specific thing, but maybe that'll at least help you remember how important it is for HHNS. Yes?
So I know both of them are critical, but if you was to have a patient with both, who would be more important? Would it be?
Well, you can't really say between one or the other, it would depend on
The situation.
that specific patient and how unstable they were at the moment. But that's a great question.
Yeah, cause you say 600 and it's like, whoa, compared to.
But see, if you
But
have
the
someone that
difference-
makes no insulin,
Yeah.
300 is as critical for them as 600 is
somebody who-
for somebody who makes some insulin.
Okay, that makes sense.
Now, the confusion with, they're gonna have the confusion, all criminal status more severe with HHS, because they're depleting all of their electrolytes, because their urine is so bad.
Yes, yes, yes. And, potassium is gonna be something that you have to really watch for, because you're getting rid of all the water, you know, and sodium follows water, and then so, and this is something too, I wanna make sure you guys understand, there'll be a difference between the serum potassium level and the total body potassium level, same with all the other electrolytes, because when you're so dehydrated, your serum potassium level can look elevated, but if you look at the total body potassium level, it will be low because they are so dehydrated. Do you understand the difference in that? Okay, does that make sense? And that'll be that way for all of your electrolytes, but obviously, remember our,
Can you explain why?
okay, so there's not much fluid. If you look at, here's a jar, and it's got, we'll say there's 20 potassiums in there, okay? And it's a liter of fluid, a liter of water, okay? So that's what's in the whole body, is 20 potassiums. I know that's just crazy number, it's just a number, okay? But in the vessel, your serum potassium level will be elevated, like because there'll be those 20 potassiums are in the vessels, they're not in the cells where they normally are, because you normally have potassium in the I'm sorry, can you all hear me? Yeah. Okay, especially if I don't have a mask on, you can probably hear me. But you normally have, say you normally have 20 potassiums, but 10 of them are here and 10 of them are here. But right now, like 19 of them are here, and you just got like one over here. So this looks like it's elevated if you just took, because you take a chunk out of a fluid out, and you look at it, so it looks like that it's elevated, but the total body potassium is low, severely low, because you don't have the potassium in the cells, because you're so dehydrated.